I'm Renza from Diabetes Australia, and thank you so much for joining us for today's Facebook Live. And as you can see, I am joined by an absolutely stellar lineup today. We have Melinda Morrison from the NDSS, we have Rachel Freeman from the ADEA, and we have Glynis Ross from the Australian Diabetes Society, the ADEA. So Glynis, I'm going to start with you. Today we're talking about gestational diabetes, which we will probably be referring to throughout today as GDM. Could we start, please, with a definition? What is GDM?
Okay, so gestational diabetes is a type of diabetes that first gets picked up during pregnancy, and at present it's affecting about 1 out of every 6 pregnant women in Australia, so it's quite a common problem. The problem in pregnancy is that the pregnancy hormones cause insulin resistance, and if you've got insulin resistance, it means you need a lot more insulin to control your glucose levels and try and keep them close to the normal range. So if you can make a lot more insulin, you manage to not get gestational diabetes. But if for some reason your body can't make as much insulin, extra insulin as you need to control your glucose levels, on standard testing, you basically get told that you've got gestational diabetes because your glucose levels are higher than they should be in pregnancy. And some of the reasons that women get gestational diabetes are things that are beyond their control because they're a bit older, or they're in an ethnic group where there tends to be more diabetes, or there's a lot of family history of diabetes. For some women, there can be some modifiable factors such as weight or diet that can be modified, again, for risk factors to try and reduce the risk of diabetes in the pregnancy.
Okay, thank you. So we're talking about gestational diabetes today because yesterday Diabetes Australia launched a new position statement together with the Australian Diabetes Educators Association and the Australian Diabetes Society. Melinda, I might throw to you. You lead the NDSS Diabetes and Pregnancy Priority Area, which isn't only about gestational diabetes. It's actually also about women with type 1 or type 2 diabetes and pregnancy. But today we're focusing purely on gestational diabetes. Could you tell us a little bit about the work that this program has done, and specifically maybe about the position statement?
Sure. So the NDSS Diabetes and Pregnancy Priority Area, as you said, does focus on diabetes and pregnancy for women with type 1, type 2 and also gestational diabetes. Specifically in regards to gestational diabetes, what we're looking at is making sure that through the NDSS we're providing information and support to women who are diagnosed with gestational diabetes throughout their pregnancy and then also after their baby is born. So as part of that, obviously there's a big online component to the information and support that we provide, and we have a lot of online resources, booklets, fact sheets. We've recently developed a series of videos about gestational diabetes and its management for the NDSS website. Women also have access to the NDSS helpline information and support. And as part of the postnatal management and support, there's also the National Gestational Diabetes Register, which is part of the NDSS.
Okay, thank you. Rachel, welcome. Rachel's from the Australian Diabetes Educators Association. Rachel, can I ask, how is gestational diabetes diagnosed? I live with type 1 diabetes, so this was one and probably the only thing that I didn't have to know about really while I was pregnant with my daughter a long time ago now. So tell us about how gestational diabetes is actually diagnosed.
Yeah, sure. Thanks, Renza. When a woman is pregnant, they will go through certain screening blood tests and other sort of screening exams that pick up lots of different things. One of those is for gestational diabetes. So they will have a glucose tolerance test around the 22 to 26 week pregnancy mark, and that will eventually diagnose or not diagnose gestational diabetes if their parameters of glucose come back above the range.
Okay, thank you. So the way that these live chats work really well is when we have lots of questions and comments come in from people who are watching. So please don't be shy. You can just add your comment in the comment section on Facebook, or you can send a direct message to Diabetes Australia if you don't want anybody to see your question. We can absolutely deal with anonymous questions. We have a comment from Anna who says, this is such important information and thanks for sharing. Thanks for your comment, Anna. Glynis, why do we need to be talking about gestational diabetes? You said 1 in 6 pregnancies are impacted by GDM. This doesn't sound like it's something minor. This sounds like something we should be talking about a lot.
Yeah, so look, gestational diabetes really is by far the most common complication during pregnancy. And the reason it's recommended that all women be tested, all women who don't already have diabetes get tested for gestational diabetes, is that firstly, we can't really just screen on risk factors, but we know that if the glucose levels are running higher in the mums, then the babies are getting extra glucose coming through to it. And the baby then has to make extra insulin, and it tends to lay this extra glucose down into fat, which isn't a good growth. So the babies can often be quite a bit larger. The other thing is that we know that if there is gestational diabetes and it's not treated well, that the risk for high blood pressure in late pregnancy is also significantly increased. And that is an extra complication that can be quite troublesome. And we know that if we control diabetes well in pregnancy, we reduce that risk back down towards the background level for the population. And yeah, so in pregnancy, it's predominantly an issue with growth and the well-being of the baby. So yeah.
So can I ask, you mentioned, you know, if the gestational diabetes is not treated, there can be some not great outcomes. Talk to us about treatment. What does treatment look like?
Yeah, so look, the basic focus of treatment is to try and do as best you can with modifying anything we can with lifestyle. So trying to make sure the diet is nutritious to meet the nutritional needs for pregnancy, but also to try and reduce the demand for insulin. At the same time, in pregnancy, carbohydrate is an essential nutrient for the baby. So the baby's brain absolutely requires carbohydrate. Low carbohydrate diets are quite worrying in pregnancy. And so a reasonable amount of carbohydrate is needed, but we want to control it at meals so that the body has a chance of making enough insulin to keep the glucose levels okay after the meal. So the diet is very, very important, and a lot of dietary support is needed. Now, a number of women really already have very good diets, but they may need to still do some tweaking just to meet those fine-tuning. Others may need to make some more adjustments to their diet. At the same time, some exercise. So in general terms, in all pregnancies, some exercise is important, as it is outside pregnancy, but also even just being a bit more active over mealtime. So, 15-minute walking around or just moving around, doing a bit of housework or whatever else is required after a main meal can help the muscles take up some extra glucose without needing quite as much insulin to cover the meal needs. So just, again, some modifying ways of activity over mealtimes can help. Now, with the majority of women, this will work and control the glucose levels within target range. But around about 30 to 40% of women, the glucose levels are still going to be above what they should be in pregnancy. And that's where medication may be required.
Okay, all right. We'll come back to that where we'll talk about medication and what that looks like. But Melinda, there's a lot of information here. There's a lot of information that we're talking about. So where can women find this? Where can people go to find this? Because I know that you've been working on developing some really great resources and booklets and videos for women who want this information, yeah?
Yeah. So when women are first diagnosed with gestational diabetes and registered with the NDSS, they're automatically included on the National Gestational Diabetes Register. And from there, women are sent lots of information from the NDSS. So some of this is in the post. They get a welcome email, which links them into information via the NDSS website. They get a booklet called Caring for Yourself and Your Baby, which outlines some of the things that Glynis has been talking about, a basic overview of the management of gestational diabetes. Obviously, what the NDSS provides is not the clinical support that we're talking about from the health services, but it's additional information and support and information to get women started on managing gestational diabetes from the outset. So women can access information that way. They can also access information from the NDSS website. So as I mentioned before, we've now got a series of videos, 10 different videos on different topics about gestational diabetes and how it's managed on the website.
Wonderful. And are we hearing from women who have lived with gestational diabetes in those videos? I think that having that personal story is really important, isn't it?
Absolutely. And that was what we heard from women when we did some consultation around what it was they wanted in the videos. And it was really about talking or hearing from other women about their experiences. Obviously, there's a health professional component as well. So we get expert health professionals to talk about management, different aspects of management, and the women share what that was like for them during their pregnancy, or there's actually women in there that are currently pregnant, what it's like for them at the moment as well. And that's, I think that personal part of it is really resonates with women who are currently going through experiencing gestational diabetes.
Yeah, I think there's that real sweet spot. We need the clinical information, and that's always, you know, very important that we understand that. It's very reassuring, but knowing that we're not walking any path alone and that there are other women who will have been experiencing this or are currently living with it is always something that really is quite supportive, I think. So absolutely. Terrific, that's great. So we'll be putting up in the comments section where people can go to find this this information. So we've got a question. When people are at risk of gestational diabetes, for example, they have a family history of it, or of type 2 diabetes, or of gestational diabetes, can these people be notified to take advice before considering pregnancy? So let's ask that perhaps in a different way. Is information available? I mean, I know that as a woman living with type 1 diabetes, from when I was diagnosed, I was told you must plan your pregnancy. I remember my endo once saying, after you tell your partner, you tell me. That was the, you know, but we had spoken about it so much beforehand. But I feel that for women with gestational diabetes, often the first time they hear about this is perhaps when they're told they need to go for their screening check. Are we talking to women beforehand? Is this part of pregnancy planning? Rachel, can I ask you that? And then Glynis, maybe I'll ask you about that as well.
Yeah, sure. Thanks, Renza. It's not talked about as much as we would like. So I guess the point of the position statement coming out and the fact that it was mentioned in the National Diabetes Strategy through the government a few years back now as one of the key points that we need to work on is that it's not being planned for and talked about enough. The planning for pregnancy and ensuring that people are eating well, exercising, having a healthy weight range before they fall pregnant are really key points that we would really like more of the general population to be working on, I suppose. We've been working with Dietitians Australia on a few projects in the last few years to try and gain a bit more traction in planning around pregnancy and having services available such as dietitians appointments, exercise, programs for people planning pregnancy, and really getting the community and the government to recognise that having those services available is really important, even in the early pre-pregnancy and pre-planning pregnancy stages. So getting to, looking at healthy eating, healthy weight, exercise as a general part of life, even when you're not planning for pregnancy, is really important when you do fall pregnant. So we know that many pregnancies aren't planned. And so that's where it becomes really tricky in trying to make sure that whole population message gets across.
Yeah, yeah. Have you got anything to add to that, Glynis, before I ask you a next very tricky question?
Okay, we'll wait for the tricky one. Basically, look, I think that really the issue is trying to encourage all women to try and plan their pregnancies, and that's for very many reasons. It's not purely just for diabetes, so a lot of things should get looked for and checked beforehand. But one of the considerations is to have the risk for diabetes assessed. And even though we've talked about diabetes that's first diagnosed in pregnancy, and for the majority of women by far, it will be diabetes that is new in pregnancy. We do have some women coming in with being picked up with gestational diabetes, but indeed already had diabetes or pre-diabetes without realising ahead of pregnancy. And that adds even further risk, to be honest, to the pregnancy. And ideally, it would be good if that could get picked up. But even as part of the pregnancy screening, it would then be good for the conversation to start about gestational diabetes being one of the common potential complications. And most women coming into pregnancy seem to be very aware of hypertension risk. And that seems to be the one complication they're very conscious of. They seem remarkably less aware of gestational diabetes risk. They may, if they've known someone else who's had it, or if they have got a strong family history of diabetes, consider it. But it's really quite interesting, considering gestational diabetes is almost 3 times as common as hypertension in pregnancy, that there is so little awareness of it. And the other conversation also is, once they are first pregnant, to be raising it again then, and whether that's through the general practitioner or the midwives. It is, I think it's very unfortunate if it is only first broached with the news of the diagnosis. I think that's very, very difficult.
Yeah. Okay. Now, I know that quite often when we read information about gestational diabetes, and thankfully this isn't on the website that and the information that Melinda was speaking about, GD is presented as this happens in pregnancy, but it goes away once the baby is born. And it's almost like this really lovely, and there we go, we don't need to think about it again. That's not what we're saying though now, is it? We're absolutely saying that this isn't something that just disappears and you never need to utter the words diabetes again. What are we actually saying now, Glynis?
Yeah, so I think it is very difficult. Certainly the words of, look, it'll go away after the pregnancy is very commonly said. And I think part of the reason is to try and reduce some of the stress in the women, but I think it's an unfortunate way of approaching it. And the reality is that we know that women who have had gestational diabetes are at high risk of developing diabetes down the track. Now, a few women, unfortunately, will have diabetes continuing straight after the pregnancy, but for many, it may be a few years later. But by 10, 15 years later, about 50% of the women are likely to have diabetes, or at least pre-diabetes. So it really is quite worrying statistics. And again, about 7 times higher risk for developing type 2 diabetes down the track than for a woman who didn't get gestational diabetes at all. So very, very high risk. And the other thing with that is that we know that we can reduce the risk. We may not be able to 100% stop diabetes happening, but we can delay it if we then set up programs and encourage women to be carrying on with a healthy lifestyle, doing the best they can with weight control, and periodically having testing done down the track, so that if any abnormal glucose tolerance, whether it's diabetes or pre-diabetes, starts appearing, that it can be addressed quite early on. So it really is very, very important for the women to understand their risk of diabetes and indeed associated heart issues down the track.
Yeah. So is this sort of that thing? I know that, in a perfect world where we have brilliant continuity of care throughout our whole life, we would be seeing the same general practitioner, for example, and this would be something that our GP would have front of mind and, would be being discussed a couple of times a year. But that isn't the reality. So is a woman who's had gestational diabetes, is it sort of this thing that she needs to take that on herself, which, is always so tough to take on more things, but to actually say at all healthcare appointments, I had gestational diabetes, so that it becomes something that we're thinking about. I think, Rachel. Thanks, Glynis.
I think we all need to be advocates for our own healthcare and our own well-being. And I think this is a particular example of the reasons for it. And I think that one of the roles of the health practitioners is to try and give the women enough information that they understand what they need to do down the track, and the responsibility should predominantly be responsibility is probably not quite the right word, but it is in the women's own best interest to be advocating for their own health needs down the track and to make sure that they do get testing done. And I know that it, again, gets scary and it can be easy to put off doing a test because you don't want an abnormal result coming back. But burying the head in the sand doesn't help either. And if you know that you've got something to tackle, it gives a motive to try and address that as well. So I think it is really important for women to have a very good understanding of diabetes, of gestational diabetes, but of diabetes risk as well, and to be promoting their own health needs with any future health practitioners they have.
Yeah, absolutely.
Renza, can I talk about the National Gestational Diabetes Register there? Because it links into what Glynis has been saying.
Yep.
This is a register that's part of the NDSS. So as soon as women are registered on the NDSS with GDM, they're on the National Gestational Diabetes Register. So it's effectively a reminder service where women and their nominated GP get sent a schedule of reminders about the postnatal checks that they need to have done, the importance of these checks, and women also get sent healthy lifestyle information after their baby's born as well. So the aim of the register really is to help women to manage their health into the future. They get a lot of support during pregnancy, but we've often found that postnatal follow-up can be fragmented, and women say sometimes they feel a bit abandoned after their gestational diabetes pregnancy because that level of support that they've been used to from their health professionals gets a little bit lost, I guess. And so the aim of the register really is to continue to remind women and also their GP. As you said, though, women often are changing GPs. It's probably not like it was back in the day when you did have a GP for life. So we're really now working to try and look at how we can make sure women staying in contact and we're keeping their details up to date, so we know that we're sending the information to the correct health professionals. But then also we've recently reviewed the messages within the communications that we've been sending out to women, and as Glynis said, really encouraging them to remind their GP that they've had gestational diabetes so that they do get those follow-up checks. And we've also tried to help women understand what those checks will look like. So some women might think that, they have to have a glucose tolerance test every time they're having a diabetes check for the rest of their life. Now Glynis might want to elaborate on this, but that's not necessarily the case. So it's about understanding what that follow-up will look like and then where to seek that follow-up, and really, as Glynis said, getting women to remind their health professionals that they have that risk and that they need to, to be able to seek that follow-up through their health professionals.
So Mel, how long do women receive this information? Is this something that is, forever, or is there a time period that they'll continue to receive information from the NDSS once they're on the register?
Yeah, there's a schedule of reminders that women get sent. So the first reminder after their baby's born is in relation to the postnatal glucose tolerance test that's recommended 6 to 12 weeks after their baby is born. And then we send them some further information a little bit down the track once kind of things have settled down. Being a new mum, we all know it's a busy time and quite difficult to take a lot on board and prioritise your own health. So further down the track, around 6 to 7 months after their baby's born, they get sent some healthy lifestyle information around reducing their risk. And then they receive annual reminders from the Gestational Diabetes Register, which goes to both themselves and their nominated GP for a period of 5 years.
Okay, good. Rachel, if a woman is diagnosed with gestational diabetes, what's the role of a diabetes educator? I know that diabetes educators are critically important and valuable for people living with type 1 and type 2 diabetes, but what can you tell us about what educators do for women with gestational diabetes?
Yeah, so when the diagnosis is made, they'll be referred to a credentialed diabetes educator, and that diabetes educator will teach them all about gestational diabetes, exactly what Glynis has been talking about, that education about what it is, what it means for the future, covering all the things that they will need to do during pregnancy, but then, as Mel said, also after pregnancy, so trying to remind them of those follow-up appointments after pregnancy as well. They will go through blood glucose monitoring, how to do that. Clinics will often provide the blood glucose monitor for them. Teach them how to use it and how often, what times of the day to check their glucose levels. They'll also do a bit of education around healthy eating and physical activity, but usually part of the team is also a dietitian, exercise specialist, those sorts of things as well. So the diabetes educator is there to really talk about what the diagnosis means, what it means in terms of risk factors for the mum and the baby, and then keep managing that. I guess just to add to the follow-up, so as Mel and Glynis have both said, that once the baby's delivered, there's obviously that, or often that discontinuation of services, so why the NDSS register is so important to be a part of.
Yep.
At ADEA, that's what we're really advocating for. So often the credentialed diabetes educator will be seeing the pregnant woman every 2 weeks, every 4 weeks, that really constant regular follow-up and education, checking in to see how they're going. But once the baby's born, there's often those services that disappear. They don't need to attend those clinics anymore because they no longer have gestational diabetes. We're really advocating for that follow-up after delivery as well. I know we haven't talked about medications yet, but something else the diabetes educator will talk about is any medications that might be prescribed, and if it is insulin, how to use their insulin, how to inject, those sort of injection techniques, and then what to check for if things aren't going well, if glucose levels are too high or too low, and those sort of troubleshooting around particular things that might be to do with their medication.
Okay, thank you. So let's talk medication, and then we're going to go, we've got a heap of questions. But firstly, Glynis, could I ask you, if women do need medication, what does that look like? Can you talk us through that, please?
Yeah, so obviously there always needs to be some individual consideration. So it's not always going to be a one size fits all, but the most common treatment would still be insulin. Insulin is a large molecule that doesn't get through the placenta, so it doesn't immediately impact on the baby. We know it's safe. It works very well. There are some women who may be able to get managed with a medication called metformin. All other diabetes medications are not advised in pregnancy, so we haven't got a huge array of options. If metformin is used, some women struggle to tolerate it, because it can upset the tummy. It still may not be effective enough on its own, so insulin still may be required anyway. And we do know that there is some passage of metformin across the placenta to the baby, and that has led to some ongoing concerns that it's not quite fully confident that it's a perfectly safe medication. So it is an argued area, so I don't want to get into it too greatly beyond that, because it is a hugely argued area both nationally and internationally. But that's basically the way it goes. Yeah. So whichever medication, it really does need to control the diabetes very well. Yeah.
So if insulin is taken, is that, what does that look like? Does that look like it?
So it'll be insulin. Yeah. So it'll be insulin injections, and it again depends really on the woman's individual needs. There is not one size fits all. So for some women, it may be just one dose of insulin a day. It may be before a meal. It may be before bed. For some women, it may be more injections a day. So it would not be uncommon to have 4 injections, a quick-acting insulin to cover meals and a long-acting at night. A few women are really, really resistant to insulin and may require some daytime long-acting insulin as well. But it is a minority, fortunately. But yeah, so it can be quite intense. But the insulin in this setting is continued until the baby's being born, or until delivery, but not afterwards. So it's very different to having type 1 diabetes. And certainly one of the questions that is commonly asked is, if I start insulin, is my body going to get used to it, and do I then have to stay on it all the time? And trying to explain, look, this is a different situation. We're just topping up the insulin that your body isn't quite able to make. Your body's making some insulin, it just needs a bit of help in this situation where there's high demand. But once that extra demand is gone after the pregnancy, you won't need to stay on it.
Yeah, great. Okay, now this is a really important question, because we've spoken a lot about mum here, and or the woman who's pregnant. We've touched a little bit on what the risks to the baby can be if glucose levels are too high in the mother and the glucose crossing the placenta. But let's talk beyond that. What are the risks for the baby after delivery? Are they at a greater risk of developing, well, the question is, are they at a greater risk of developing type 1, type 2 or gestational diabetes in their life? So what do we know there, Glynis?
Okay, so it's complicated. So we certainly know that the children are at a high risk of a number of things. So they are at risk, not when they're being born, they're not going to be at risk of diabetes at birth. So that's very important to be aware of. They are at high risk, particularly beyond adolescence and into young adulthood, of having more struggling with weight more. So they may have a bit more weight issue. They may run into a bit more trouble with blood pressure. They may start running into problems with pre-diabetes or type 2 diabetes. The risk for type 1 diabetes in the children of a mum with gestational diabetes is low. It's not 0, but it's it's a low and not much increase in risk. So the main issue is for risk for the child that probably because of programming while the baby's in the uterus, that the baby's pancreas develops a little bit differently, the fat tissue develops a little bit differently, that the child will be at higher risk of getting into trouble a bit earlier. And so encouraging the child, again, providing a healthy lifestyle in the whole family is really, really important. And certainly encouraging the child as they're going through school and into high school to be physically active is going to be very important, aside from just the focus on diet.
Yeah, okay. Rachel, a quick question for you. What information is available from the ADEA for health professionals about gestational diabetes?
We do have a learning management system where we host a number of different e-learning modules and webinars. There will be coming out a new webinar on gestational diabetes and the position statement that's just been released. We do also endorse other activities. So one of those is the NDSS activities that Mel develops and looks after. I'm happy for Mel to talk about that, but we do have a few links to that on our website as well.
Okay, thank you. Now we've got a question from Susan who says, can HbA1c be used post-pregnancy as the annual checkup? So Glynis, would you like to answer that?
Yes, with caution.
Okay.
So it's not a very sensitive test. Outside pregnancy area altogether, an HbA1c of 6.5% or higher is accepted as being consistent with diabetes. But in reality, you could have an HbA1c lower and still have diabetes. So it needs to be done with care. But certainly, as Mel said, there is a trend away from doing all follow-up with glucose tolerance tests. And the combination of a fasting glucose and an HbA1c every couple of years is viewed as reasonable. But considering perhaps doing a GTT if the HbA1c is trending towards 6% or more, because that may already be signaling some pre-diabetes, and that may just be a little bit more incentive if there are modifiable lifestyle things that can be done to try and delay any further progression into diabetes. So yes, the answer is yes, but with caution.
Okay, thank you.
Glynis, could I also ask if you could talk about women who are planning another pregnancy?
So that's where there's a little bit of difference. So if a woman is planning another pregnancy, I don't think an HbA1c is the right test to be doing in follow-up, and I think that's when a glucose tolerance test is required. Again, it's very difficult to set a one-size-fits-all in a recommendation. So if a woman is already known to have pre-diabetes, because they've already had impaired glucose tolerance after they've had gestational diabetes, I would certainly be recommending that they have an annual glucose tolerance test ahead of a pregnancy. If she'd required a lot of insulin, or if her glucose tolerance test results after the pregnancy were getting a little bit borderline, I would also suggest that she be having a further GTT about every 12 to 18 months between pregnancies. If she's had a 100% normal glucose tolerance test and she falls pregnant again with, plans to fall pregnant again within 18 months to 2 years, I don't really think that it's critical to have a GTT, to be honest, at that time. And I would then be testing in pregnancy, but I would be testing initially probably around 18 to 20 weeks. Yeah.
So a question, we might have some women who are watching who have had a pregnancy and have had GDM and they're considering a second pregnancy. What is the risk that they will get GDM a second time or a third time around?
Yeah, so published risks actually vary very widely between 20 and 80%, depending on the local population and what testing they've done. Okay. In reality, I would actually say it's around 80 to 90% risk that it will occur again. Yeah.
Okay. Okay, so something to obviously have front.
It's something to be very aware of. And again, if there are modifiable risk factors that can be done with diet or exercise ahead of pregnancy or modifying weight, that would be really, really good to do ahead of the pregnancy. And we particularly know that if women gain weight subsequent to the first pregnancy, that is a very strong risk for developing gestational diabetes in the next pregnancy. So avoiding future weight gain becomes incredibly important. And if they've been overweight, it is really an advantage to have lost some weight ahead of the next pregnancy.
Okay.
Makes a big difference. Yeah.
Now, I'm not sure who wants to answer this, so let me just throw it out there. But you know, pregnancy is a time of a lot of change. It's often also a time of concern and worry and a bit of anxiety. And women who are diagnosed with gestational diabetes, just as with other health conditions, that burden of worry can actually be quite a bit heavier, I guess. What is available to women if they are feeling that they're feeling really concerned? They're worried about themselves for their pregnancy, but they're also worried about their baby. What would you recommend, or who do you recommend that a woman might speak to help support her if she is feeling like that? Rachel, have you got some ideas?
Yeah.
Perhaps let's start with you and then, yeah.
Yeah, sure, I can start. So definitely talk to your diabetes educator about those feelings. We would recognise that would be quite common in a lot of women with GDM. There is a lot of pressure. There's a lot of pressure to check your glucose levels and eat the right foods and at the right times, get that exercise in. We understand that there's a lot of distress around that, or there can be. We do have other women that like the structure actually, so that they, if they talk to their dietitian or diabetes educator, and they know what to eat at each meal, and there's quite a bit of a structure around that. It takes a bit of the guessing around what they need to do. So it just depends on the person again, and we individualise that as much as possible to really keep their glucose levels in the right ranges. So talk to your diabetes educator or whichever health professional you're seeing about your GDM, and there will be referral pathways that would be utilised to social work support or psychology support if those services are available. Again, at ADEA, we're really advocating to government to increase those services as much as we can possibly do. We know that government at the moment is very focused on COVID, but this is a really important topic, and the support for women needs to be there if we are going to change the trends or prevent further GDM or even type 2 diagnosis.
Yeah, just most antenatal services do have pathways, and outside diabetes, many women for many reasons have a lot of anxiety or a lot of stresses going on in pregnancy. So it's been highly recognised that part of pregnancy management, and this is whether it's in public or whether it's in private, it doesn't matter whether it's midwife shared care, GP shared care, or in a specialty service, that there should be a lot of mindfulness about psychosocial assessments, and that there should be pathways for women who are undergoing any levels of stress. Now, clearly, as Rachel said, basically in the diabetes area, specifically with diabetes, there is going to be quite a lot of understanding with the diabetes health professionals on the diabetes specific issues, but it may be just one of the things that's factored in. So the women definitely need to present to any of their health carers, whether it's on the obstetric side or the diabetes side, and ask for help.
Yeah. I know, Melinda, there is a psychologist working with you on the NDSS project, the wonderful Crystal Hendrix, who we interviewed as part of one of our Facebook Lives a few weeks ago. So I know that that's certainly considered, isn't it?
Absolutely.
In the resources that have been developed around gestational diabetes. Yeah,
absolutely. Crystal's been a
now,
great supporter.
One of the things that I really, she's terrific. She's great. One of the things that I think is really important in the position statement is that there is no punching here. This isn't in any way, making women feel that that they are responsible and that, or in terms of, it's their fault in any way. And I think that's really critical, because when we're talking about this isn't just what's happening now, this has this could impact on your child. Feeling that guilt is often something, mother guilt is so huge already. This seems to be adding to it. So I think it's really important the way that this has been, addressed in the position paper, is that it's not all about finger pointing and putting all this blame on a woman, during her pregnancy. So was there thinking, maybe Mel, if you wanted to answer this, was there thinking about that when you were putting together the position statement, to look at, what can be done? How can government support? How can communities support? Was that a really important consideration in the development of the statement?
Absolutely. And I think one of the things driving this is the fact that we're talking about the fastest growing type of diabetes in Australia. So in the next decade, we're expecting you know, more than 500,000 women to have developed gestational diabetes. So we really need to look at, you know, in the position statement, there was very much a focus on how we can improve services that are being delivered to these women, and where the gaps are and what's needed, not just during pregnancy, but throughout their, you know, their lifelong health is a really important part of the position statement.
Yeah, thank you. Okay, we're going to wrap it up. So let's just do a quick whip around with, I guess, perhaps, you know, words of wisdom to women who are either pregnant at the moment and have gestational diabetes, are concerned about it, have had gestational diabetes. What would be the key message that you would like them to take away from having listened to this? And Glynis, I'm so sorry, but I'm going to start with you.
Okay. I think one of the issues in pregnancy is it's really important for the women to remember that they are pregnant and that they need to enjoy the pregnancy.
Yes.
This is just one area that they need to be just more mindful of, and trying to take the positives away, that they will get some information about what is good for healthy lifestyle, with whether it be diet, whether it be exercise, some hints for other things, and take that away and build on it for down the track. It'll be good for them, it'll be good for their families. But the critical thing is they're pregnant, they're going to have a baby, they're going to have a lovely time, you know, rearing children. And I think that is one of the most critical things that they need to be focused on, and not just get overwhelmed that something has happened in the pregnancy. It ultimately, in the long run, it's going to be a little blip, even if it feels like a mountain at the time. Yeah.
Oh, I can't thank you enough for saying that. I feel sometimes that when, you know, women living with diabetes, and I'm sure that this is other health conditions as well, but I know that there were times I felt robbed of just having that normal pregnancy where the most exciting thing was what colour was I going to paint the nursery. We deserve to have those pregnancies as well. So thank you for reminding us that that's the key. Rachel, what would you like to say?
I guess on the back of that, and what I was saying before about women sometimes enjoy that contact with their health professionals. So if they have GDM or any other reason where they might need more follow-up than, say, the person who doesn't need so much follow-up during pregnancy, then just to utilise that, you know, lean on your health professionals, really use them as a support, you know, whatever you need. Just we want you to absolutely to enjoy your pregnancy. So we're there to help and just to make sure that you are educated and use that into the future, but to know that we're just there to support. So enjoy being a little bit more in contact with your health professionals, that you can just ask any questions whatsoever about any aspect of your pregnancy that you might not have been able to do without having regular contact with health professionals.
That's great advice. And Melinda, last word to you. What would you like to say?
Look, I'd 100% agree with Glynis and Rachel. Really, really important points. I guess the only other thing I would add to that is that there is support available. So for women to reach out and seek the support that's out there.
Yeah, wonderful. Thank you so much to the three of you. I know that this has been a really informative chat. So this will be available on the Diabetes Australia Facebook page forever. So you can come back and watch it again. And I know that the ADEA certainly has been sharing information about it, as has the ADS and the NDSS as well. So, hey, we're going to be everywhere. So that's great. Emily has been putting up information about where people can go for further details. I think that the position statement link will also be there. So please do go and have a read of that. But we're going to sign off now. So thank you very, very much. And we'll be back soon with another Facebook Live very shortly.